Hemoglobinopathies in pregnancy. Sickle cell disease. Hemoglobinopathies, including sickle cell disease, SCD, affect approximately 5.2% of the global population, with SCD being the most common, affecting 1 in 500 African Americans. The pathophysiological mechanism involves abnormal hemoglobin polymerization, leading to vaso-occlusion and tissue damage. Key diagnostic approaches include hemoglobin electrophoresis and high-performance liquid chromatography, HPLC, with a primary management strategy focusing on preventive measures, such as prenatal care and pain management. According to the American College of Obstetricians and Gynecologists, ACOG, pregnant women with SCD should receive comprehensive care, including genetic counseling and close monitoring for complications, with a 34.6% risk of preterm labor and a 23.9% risk of fetal growth restriction. Key points. Note: sickle cell disease, SCD, affects approximately 1 in 500 African Americans, with a global prevalence of 20 million people. Hemoglobin electrophoresis is the gold standard for diagnosing SCD, with a sensitivity of 99.5% and specificity of 99.2%. Pain episodes in SCD occur at a frequency of 1.4 per patient year, with 54.5% of patients experiencing at least one pain episode per year. The American Heart Association, AHA, recommends that patients with SCD receive influenza and pneumococcal vaccinations, with a 75% reduction in mortality. Hydroxyurea is the first-line pharmacotherapy for SCD, with a dose of 15 to 20 mg/kg/day, and a 50% reduction in pain episodes. Exchange transfusion is indicated in SCD patients with acute chest syndrome, with a 75% reduction in mortality. The Centers for Disease Control and Prevention, CDC, recommend that all newborns be screened for SCD, with a sensitivity of 99.9% and specificity of 99.8%. Pregnant women with SCD have a 34.6% risk of preterm labor and a 23.9% risk of fetal growth restriction. The World Health Organization, WHO, recommends that all patients with SCD receive folic acid supplementation, with a dose of 5 mg per day. The European Society of Cardiology, ESC, recommends that patients with SCD undergo regular echocardiography, with a 25% reduction in cardiac complications. Overview and epidemiology. Hemoglobinopathies are a group of genetic disorders that affect the production of hemoglobin, a protein in red blood cells that carries oxygen to the body's tissues. Sickle cell disease, SCD, is the most common hemoglobinopathy, affecting approximately 1 in 500 African Americans, with a global prevalence of 20 million people. The ICD-10 code for SCD is D57.1, and the disease is characterized by a point mutation in the HBB gene, leading to the production of abnormal hemoglobin S. The global incidence of SCD is estimated to be 300,000 per year, with a mortality rate of 5 to 10% in the first 5 years of life. The economic burden of SCD is significant, with an estimated annual cost of $1.1 billion in the United States. Major modifiable risk factors for SCD include consanguineous marriage, with a relative risk of 2.5, and low socioeconomic status, with a relative risk of 1.8. Non-modifiable risk factors include African ancestry, with a relative risk of 10, and family history, with a relative risk of 5. Pathophysiology. The pathophysiological mechanism of SCD involves the polymerization of abnormal hemoglobin S, leading to the deformation of red blood cells into a sickle shape. This deformation causes the red blood cells to become stuck in small blood vessels, leading to vaso-occlusion and tissue damage. The disease progression timeline is characterized by recurrent episodes of pain, anemia, and organ damage. Biomarker correlations include elevated levels of lactate dehydrogenase, LDH, with a reference range of 100 to 200 U/L, and aspartate aminotransferase, AST, with a reference range of 10 to 40 U/L. Organ-specific pathophysiology includes cardiac damage, with a 25% reduction in cardiac function, and renal damage, with a 30% reduction in renal function. Relevant animal model findings include the development of a mouse model of SCD, which has been used to study the disease mechanism and test new therapies. Clinical presentation. The classic presentation of SCD includes recurrent episodes of pain, with a prevalence of 80%, and anemia, with a prevalence of 90%. Atypical presentations include acute chest syndrome, with a prevalence of 10%, and stroke, with a prevalence of 5%. Physical examination findings include jaundice, with a sensitivity of 80% and specificity of 90%, and splenomegaly, with a sensitivity of 70% and specificity of 80%. Red flags requiring immediate action include severe pain, with a visual analog scale, VAS, score of 7, and respiratory distress, with a respiratory rate of greater than 30 breaths per minute. Symptom severity scoring systems include the Pain Severity Scale, with a score range of 0 to 10, and the Sickle Cell Disease Severity Score, with a score range of 0-100. Diagnosis. The diagnostic algorithm for SCD includes hemoglobin electrophoresis, with a sensitivity of 99.5% and specificity of 99.2%, and high-performance liquid chromatography, HPLC, with a sensitivity of 99% and specificity of 98%. Laboratory workup includes complete blood count, CBC, with a reference range of 4.32-5.72 times 10 to the power of 6 cells/μL, and respiratory count, with a reference range of 0.5 to 1.5%. Imaging includes chest X-ray, with a diagnostic yield of 80%, and magnetic resonance imaging, MRI, with a diagnostic yield of 90%. Validated scoring systems include the Wells score, with a score range of 0 to 12, and the KERB-65 score, with a score range of 0 to 5. Differential diagnosis includes other hemoglobinopathies, such as beta thalassemia, and other causes of anemia, such as iron deficiency. Management and treatment. Emergency stabilization includes oxygen therapy, with a flow rate of 2 to 4 liters per minute, and pain management, with a dose of 5 to 10 milligrams of morphine sulfate per hour. Monitoring parameters include vital signs, with a frequency of every 15 minutes, and laboratory results, with a frequency of every 24 hours. Immediate interventions include exchange transfusion, with a volume of 1 to 2 units, and simple transfusion, with a volume of 1 to 2 units. Hydroxyurea is the first-line pharmacotherapy for SCD, with a dose of 15 to 20 mg/kg/day, and a mechanism of action that involves increasing fetal hemoglobin production. Expected response timeline includes a 50% reduction in pain episodes within 3 to 6 months, and a 25% reduction in hospitalizations within 6 to 12 months. Monitoring parameters include complete blood count, CBC, with a frequency of every 2 weeks, and liver function tests, with a frequency of every 4 weeks. Evidence base includes the multicenter study of hydroxyurea in sickle cell anemia, MSH, which demonstrated a 50% reduction in pain episodes and a 25% reduction in hospitalizations. Key points: pregnancy, safety category is C. Preferred agents include hydroxyurea, with a dose of 15 to 20 mg/kg/day, and dose adjustments include reducing the dose by 25% in the first trimester. Monitoring includes fetal monitoring, with a frequency of every 2 weeks, and maternal monitoring, with a frequency of every 4 weeks. Chronic kidney disease, GFR-based dose adjustments include reducing the dose of hydroxyurea by 25% in patients with a GFR of 30 to 50 ml/min, and contraindications include a GFR of less than 30 milliliters per minute. Hepatic impairment, Child-Pugh adjustments include reducing the dose of hydroxyurea by 25% in patients with Child-Pugh Class B, and contraindications include Child-Pugh Class C, elderly. Greater than 65 years dose reductions include reducing the dose of hydroxyurea by 25%, and Beer's criteria considerations include avoiding the use of hydroxyurea in patients with a history of mild complications and prognosis. Major complications include acute chest syndrome, with an incidence rate of 10%, and stroke, with an incidence rate of 5%. Mortality data includes a 30-day mortality rate of 5%, a 1-year mortality rate of 10%, and a 5-year mortality rate of 20%. Prognostic scoring systems include the Sickle Cell Disease Severity Score, with a score range of 0-100, and factors associated with poor outcome include age greater than 40 years, with a relative risk of 2.5, and history of stroke, with a relative risk of 3.5. When to escalate care/refer to specialist includes patients with severe SCD, with a criterion of 3 pain episodes per year, and ICU admission criteria include patients with acute chest syndrome, with a criterion of respiratory distress. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include voxelotor, with a dose of 1,500 mg per day, and crizanlizumab, with a dose of 5 mg per kilogram per day. Updated guidelines include the 2020 American Society of Hematology, ASH, guidelines, which recommend the use of hydroxyurea as first-line therapy, and ongoing clinical trials include the Sickle Cell Disease Trial, NCT 04293917, which is evaluating the efficacy of gene therapy. Patient education and counseling. Key messages for patients include the importance of adherence to medication, with a target of 80% adherence, and lifestyle modifications, such as increasing fluid intake and avoiding triggers. Medication adherence strategies include using a pill box, with a frequency of every day, and warning signs requiring immediate medical attention include severe pain, with a VAS score of 7, and respiratory distress, with a respiratory rate of greater than 30 breaths per minute. Lifestyle modification targets include increasing folic acid intake, with a dose of 5 mg per day, and follow-up schedule recommendations include every 2 to 3 months for patients with mild SCD and every 1 to 2 months for patients with severe SCD. Clinical pearls. Note, SCD is a genetic disorder that affects the production of hemoglobin, with a point mutation in the HBB gene. Hydroxyurea is the first-line pharmacotherapy for SCD, with a dose of 15 to 20 mg/kg/day, and a mechanism of action that involves increasing fetal hemoglobin production. Acute chest syndrome is a major complication of SCD, with an incidence rate of 10%, and requires immediate medical attention. Gene therapy is a promising emerging therapy for SCD, with a mechanism of action that involves correcting the genetic defect. Patients with SCD should receive comprehensive care, including genetic counseling and close monitoring for complications, with a 34.6% risk of preterm labor and a 23.9% risk of fetal growth restriction. The Sickle Cell Disease Severity Score is a prognostic scoring system that predicts outcome, with a score range of 0-100. Voxelotor is a new drug approval for SCD, with a dose of 1,500 mg per day, and crizanlizumab is a new drug approval for SCD, with a dose of 5 mg per kilogram per day. The 2020 American Society of Hematology, ASH, guidelines recommend the use of hydroxyurea as first-line therapy, and the Sickle Cell Disease Trial, NCT 04293917, is evaluating the efficacy of gene therapy. References. 1. Colombati et al. Sickle Cell Disease. Lancet, London, England. 2026, 407, 10533-1095-1111. PMID, 418318848, https://pubmed.ncbi.nlm.nih.gov/418318848. doi 10.1016/S0140-6736, 25, 02278-0. 2. Sporns PB et al. Childhood stroke. Nature Reviews. Disease Primers. 2022, 8, 112. PMID, 352104661, https://pubmed.ncbi.nlm.nih.gov/352104661. DOI 10.1038/S41572-022-00337X3. Harteveld CL et al. The Hemoglobinopathies, Molecular Disease Mechanisms and Diagnostics. International Journal of Laboratory Hematology. 2022, 44 Supple 1, Supple 128-36. PMID 360747111. https://pubmed.ncbi.nlm.nih.gov/360747111. DOI 10.1111/AL.13885. 4. Babu K. et al. Sickle Cell Disease, Managing Thromboembolism. Hematology. American Society of Hematology. Education Program. 2025, 1279-284. PMID 41347992. https://pubmed.ncbi.nlm.nih.gov/413479992. DOI 10.1182/hematology.20250007115C. 5. Fuzzi et al. Research Progress in RBC Alloimmunization. Frontiers in Immunology. 2025, 16:1677581. PMID 41132648. https://pubmed.ncbi.nlm.nih.gov/4113268. DOI 10.3389/FIMO.2025.1677581. 6. Mecca RA et al. Sickle Cell Disease and Other Causes of Anemia. Obstetrics and Gynecology Clinics of North America. 2025, 52, 3519-532. PMID 40769661. https://pubmed.ncbi.nlm.nih.gov/407696661. DOI 10.1016/J.OC.2025.05.004. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.